Hello, my name is Kay Davies. I'm one of the consultant paediatric anaesthetists in the Children's Hospital, and today we've made a little video to show you front of neck access in children. So the main reasons you would do front of neck access in children is for a can't intubate, can't ventilate situation. It's really a last resort, and it's really only to be done if ENT haven't arrived yet. So you have two options. You have a cannula technique and a surgical technique. I'm going to show you both of these techniques in the video. We're also going to discuss the use of a Ventrain device, which you can find in our difficult airway trolleys and our resource airway trolleys as well. So the needle cricothyroidotomy technique is not recommended in children less than 5 years old according to APLS guidelines, and this is because the trachea is very elastic, so you need significant force to pierce the trachea, and there's a risk of damaging the posterior wall of the trachea. Children also have very short necks, so it's very difficult to actually have enough space to access the cricothyroid membrane using a needle and a cannula. The Difficult Airway Society have different guidelines. They recommend that between the age of 1 and 8 years old that you try a needle cricothyroidotomy if ENT have not yet arrived. If ENT are present, they would try a surgical tracheostomy or rigid bronchoscopy. The Difficult Airway Society recommend a surgical cricothyroidotomy for children over the age of 8 years old. In infants below the age of 1, the cricothyroid membrane is too small to pass a tube, so a surgical tracheostomy is indicated by ENT surgeons. The advantages of a needle cricothyroidotomy is that it is simple to perform and buys you some time until ENT surgeons arrive to perform a definitive airway. The equipment you need to perform a needle cricothyroidotomy include a 16-gauge cannula. For larger adult-sized children, you could use a 14-gauge cannula. You need a 5 ml syringe filled with 2 ml of 0.9% saline, and you also need some ChloraPrep to clean the skin. We also have the Ventrain device, which can be connected to an oxygen source. The Ventrain device is an oxygen delivery device which can be connected to high flow oxygen, and the other end connected to the cannula using a Luer lock connection. It has a connection on the end for capnography, which should be removed before you use it in an emergency setting. So one of the disadvantages of needle cricothyroidotomy is that expiration is passive, and you need a patent upper airway in order for gas to leave the patient. The advantages of the Ventrain device is that it uses the Venturi effect to cause active expiration through the cannula during the expiration phase. The Ventrain device is very useful because you don't need to find a three-way tap and oxygen tubing and fit it all together. Instead, it comes all included. You attach the oxygen to a high-flow oxygen source, and the other end is attached using a Luer lock connection to the cannula. The body of the Ventrain device incorporates a Venturi device inside it, and it has 2 orange holes on the outside, which can be easily covered by the thumb and index finger. Inspiration is performed by covering both orange holes with the thumb and index finger. Expiration is performed by lifting the thumb. If you need to equalize pressures, you lift both the thumb and index finger as a safety mechanism. To perform a needle cricothyroidotomy, it is important to extend the head and the neck really well to gain access to the neck. You may need somebody to hold the head. With your non-dominant hand, palpate the thyroid cartilage to find the cricothyroid membrane. Then use ChloraPrep if time to clean the skin. With your dominant hand, take a 16-gauge cannula connected to a 5 ml syringe filled with 2 ml of 0.9% saline. Insert the cannula at a 45 degrees angle caudally, aspirating as you go. When you see air bubbles, you have reached the inside of the trachea. Gently move the cannula over the needle and remove the needle. It is really important at this stage to connect your 5 ml syringe and re-aspirate. Make sure that you've got air coming back. Next, you connect your Ventrain device to a high flow oxygen source. You select the flow rate depending on the age of the child. So, for example, if the child is 5 years old, you will select 5 litres a minute. Connect the other end using the lure lock connector to the cannula. Make sure you hold the cannula really well and inflate the chest by covering both holes on the Ventrain device. Inflate for 1 second, making sure that the chest has inflated. If there's no chest inflation, it's important to increase slowly the oxygen flow rate. It's really important to make sure that your upper airway is patent, because the expired gases will need to be exhaled from the patient. So you might need someone to open up the airway or put a Guidel airway in place to help with that. However, the Ventrain device will assist with CO2 clearance through the cannula. Inspiration takes 1 second and expiration takes place over the following 4 seconds. So next I'm going to talk about a surgical cricothyroidotomy. The equipment you will need for a surgical cricothyroidotomy include ChloroPrep to clean the skin, a 15mm blade scalpel, and a tube. You use the size of tube that is appropriate for the child. You may want to use a smaller tube. To perform a surgical cricothyroidotomy, it's really important to extend the head and the neck, and it is useful to get somebody to stabilise the head. Use ChloroPrep to clean the skin. Next, with your non-dominant hand, identify the cricothyroid membrane, and with your dominant hand, take the scalpel. In the midline, do a vertical skin incision, about 1 centimetre. Next, with your left hand, your non-dominant hand, pull the skin incision apart so that the skin is stretched, and this helps to reduce bleeding. Next, with your scalpel, do a transverse stab incision in the cricothyroid membrane and gently rotate your scalpel 90 degrees to open up the hole. Then take your tube and insert this into your hole. If there's any difficulties with this, use a smaller tube. Don't let go of the tube, but get someone to connect it to a high flow oxygen source from an ambibag, and make sure you can ventilate. If you've used a cuff tube, it's important to inflate the cuff to prevent any leaks. It's important to confirm the correct placement of the endotracheal tube using capnography.